Good morning, everybody, and thank you all for having me here today. And given this time related to my departure in a couple of weeks, we thought it would be good to look back at not only some of the accomplishments over the past 4 years, but some of the things that we've learned, and try to focus on some of the things that we've published based on those learnings as well. So with that, I want to make sure that I call out that all of the things that we talked about today have been achieved by a huge team of people. So this shows the quality, safety, and service infrastructure of Stanford Children's Health. And many of the people in all of these boxes have contributed to this. And that's only part of the story. Obviously, the frontline people who actually provide the care, the nurses and physicians, have played a huge role in this. Nursing leadership, many people have been responsible for some of the successes that we'll discuss and some of the insights as well. So with that, if I reflect back on when I was first coming to Stanford to be the Chief Quality Officer, both during the interview process and when I first got here, it was made very clear that there were certain things that needed to be the priority to work on first. And some of those are listed here. We had in fiscal year 2018-24 serious safety events, and reducing those was a priority. Our central line infection rate was 2 times higher than the national benchmark, and that needed to be a priority. Our pressure injury rate was 3 times the national benchmark, and that was also stressed as a priority. And then our US News and World Report rankings have been declining, and another thing that was stressed was the importance of turning that around and working on that. So what I thought we would go through today is some of those things, plus a few other areas where we've learned about things. So we'll talk about serious safety events, CLABSIs or central line infections, hospital-acquired pressure injuries, venous thromboembolism in children, quality, safety, and service key performance indicators, and some of the things that we've learned related to social things that can affect health equity. Talk a little bit about the US News and World Report gap closure process and some of the successes related to that. And then end on talking about what I think some of the challenges facing the organization are, the importance of having a socio-technical approach to quality, safety, and service. And the challenge is particularly for Packard in managing patient complexity. So start off with serious safety events. As I believe you're all aware, almost all the children's hospitals in the United States, through the Solutions for Patient Safety, a safety sharing network, use the same definitions of serious safety events. And you have a serious safety event when there is deviation from generally accepted practice. That deviation has reached the patient and caused harm. And then that harm is defined in levels, and each of those levels have fairly stringent definitions. So those range from SSE1, which is a deviation that resulted in patient death, to an SSE5, in which there is moderate temporary harm. This is a modified run chart. It's a run chart in the sense that our performance is ranked over time. This is serious safety event rate over time. It's modified in the sense that we break these down by fiscal year. So for each fiscal year, here's 17, 18, 19, all the way to 2022. Each fiscal year has its own mean, its own upper control limit, which as that goes down, it shows a decrease in the variability. And you can see our performance over time. So you can see that compared to 2017, we had a fairly substantial drop in our serious safety events in 18. And then we've been able to sustain that level over time. We actually had a period recently where we actually went 210 days without a serious safety event. And that was the longest stretch we've ever had as an organization. So There has been a significant reduction in these events. We have, for the past several years, had somewhere between 7 and 10 events per year. Of course, we would like that number to be 0, but given again, the level of complexity of our patients, that's a very hard thing to achieve. Some of the things that have contributed to this reduction in rate would include, every time we have a serious safety event, we have a root cause analysis looking into that event, and that results in the creation of an action plan to try to prevent such an event from occurring again. And if your process is any good at doing that, obviously the things that are either recurrent or events that have occurred should be stopped from happening, or at least made the chance of them happening at a lower frequency than has been in the past. And I believe that through going through that process, that is what has happened. So this is one example. This chart actually shows days between serious safety events. So unlike when you want your rate to come down, you want your days to go up. So up is the desired direction here. And this is for the perioperative area. So you can see that we had a period of time here where we had multiple serious safety events related to the perioperative area. They were all really coordination issues, having the right consent, forgetting to do a minor procedure or doing a minor procedure that wasn't consented, or not having the right equipment resulting in a prolonged period of time of the patient being under anesthesia, things along those lines. They instituted a AM huddle where all that coordination thing for each case in that particular room of the day was discussed at the beginning of the day to make sure that all the right things were in place. And through that process, they have gone much longer without a serious safety event related to the perioperative area. So this is one example. Another thing that comes to mind is we had several serious safety events related to CRRT in aqueducts therapy. Group worked on that. Those events have not happened recently. So if you have a number of incidences where you put in things in place to prevent those things, your rate should go down, and that has been the case. This is a publication that we wrote related to the timeliness of both declaration of serious safety events and the performance of the root cause analysis to come up with those action plans. Obviously, if a serious safety event occurs and could occur again, it is important to get that action plan in place as quickly as is reasonably achievable. And if you look at our baseline before this initiative, which occurred here, this displays days between when we knew of an event and when we decided to declare a serious safety event. So before the initiative, it took us 38.4 days on average, and some days times as long as 127 days to do that. And then this side shows the length of time it took us to do a root cause analysis, and that's a 2-meeting model. So this was the amount of time that you had the 2 meetings and created the action plan, not actually executed the action plan. So here you can see that before the process change, it took us on average 118 days to schedule and complete the root cause analysis. Our goal was to be below 30 days, and afterwards, until now, we have had a mean of 26 days, so are making that 30-day goal. Now, 18 times, that's the period of time. So we want that period of time to be as short as possible. So once those action plans are created, they then go at repetitive times in front of what we call the executive value committee, where hospital executives and physician and nursing leaders are, to make sure they actually get completed. So we have all this infrastructure that we've used for patient safety. And one of the other things that we decided to look at was, why not use that same infrastructure, because it would be efficient to do so, to look at healthcare worker serious safety events. So we put in place a program to create this healthcare worker serious safety events. And we took the patient safety guidelines from Solutions for Patient Safety and interpreted those to what they would mean for healthcare worker safety events, graded them from 1 to 5, based on many of the same things as in patient safety. And now, every time that we have a question of a healthcare worker serious safety event, that goes to that same event review meeting. If it's determined to be a healthcare worker serious safety event, a root cause analysis is performed just like one for patient safety, and an action plan put in place, and that action plan reviewed throughout the executive value committee until completion. And I think that's important for a number of reasons. Here's the Packard website that shows the days since the last serious safety event and the days since the last healthcare worker serious safety event. You know, this sends the message that not only is patient safety important, but healthcare worker safety is also important. It puts the infrastructure in place to make sure that those gaps get closed. And I think that has served the institution well. Another way that we looked at our experience in patient safety and the infrastructure created to do it, to try to capitalize on that infrastructure, was the creation of something that we call serious experience events. And a serious experience event we define as an event in which there is deviation from our standard practices or an identified system issue related to our current standard practices that has caused significant compromise of the patient and or family experience. The key word there is significant compromise. And how is that defined? We define that as, it's subjective, but an event that would be seen as egregious by reasonable public standards, and that is also likely to leave a lifelong lasting impression on the family. Interestingly, you know, we have a lot of debate in the event review meeting about serious safety events and whether they are one or not. We usually don't have that same degree of debate about serious experience events. So, you know, even though it's subjective, when you see one, you kind of know that it should be one. And then these undergo the same root cause analysis and action plan and accountability to make sure those action plans get complete, use that same infrastructure as patient safety. So those are some of the things we've learned about serious safety events. I'd like to move on to line infections, or CLABSIs. And this is, again, a modified run chart. And this shows our performance with our CLABSI, our non-mucosal barrier injury or non-MBI CLABSI rate over time. Our rates for all CLABSIs looks very similar to this. But you can see that the yellow line here is the national benchmark. This is the mean CLABSI rate for children's hospitals through Solutions for Patient Safety. And you can see that in 2017, we were well 2 times actually above that mean. And through the next 2 years, we had an initiative involving the entire enterprise to reduce our CLABSI rate. And you can see that our mean per fiscal year dropped then significantly below the national rate. And then the amazing thing is the hospital has been able to sustain that rate below the average. And if you look at 2022, thus far, we're doing amazingly well, and this rate is lower than it's ever been in a fiscal year. So great work by all the frontline providers and those who support them. This is a different way of looking at our CLABSI rate. This is the standard infection ratio, and basically the NHSN looks at our data, and based on our patient complexity, gives us a SIR ratio, and that ratio is the number of actual CLABSIs that you had compared to the number that they would have expected you to have based on your patient complexity. And that if that rate is more than 1, you have more CLABSIs than they would expect you to have. And if it's less than 1, you have less. And you can see this is data from 17 through 21. And these are the SIR numbers, and you can see we went in 17 from having a 1.27, which was well above the rate, to progressively downward to, in 2021, 0.399, so less than half of the CLABSIs that they would have expected us to have based on our patient complexity. So again, amazing work by everyone at the hospital. Now, this initiative involved a very large number of people, and you can see in that photograph that the number of people in one particular meeting back in 2017-18 to work on this, and there were multiple nursing-led RPIs and other initiatives. I would say that the historic problem was not that people weren't working on CLABSIs, but more that they were working on their own initiatives in their own units, and it wasn't standardized between the units. And as providers and patients move from one unit to another, the rules could potentially be different than the different areas. So looking back at our experience in trying to reduce the CLABSI rate, this was an article that was published, and one of the main things out of that article that the team working on this realized is that there are buckets of key drivers that are important if you want to reduce the rate. And this turns out to be true not just for CLABSI, but really everything that we worked on. And these are those buckets. One is standardization. As has been said, you can't have improvement without standardization. So making sure that practices are standardized as possible is a key thing. Data transparency. You have to make sure that the people on the front lines who you're expecting to improve understand what their current performance is. So the data has to be available to show them, because you can't really expect them to improve if they don't know how they're doing. The third thing is accountability, making sure that everybody involved in that particular aspect of care realizes that they are accountable for those things to occur, and that those things are well defined. And then I would add coordination. I think this is true everywhere, but particularly at a place like Stanford, where there's such an emphasis on innovation, and that anyone can really start an innovation at any particular point in time. It's important to make sure that all of those sources of innovation are coordinated and not conflicting. Interestingly, we have this program SURF that David Shanker runs, and there were SURF students that were involved in helping create the dashboard to look at bundle compliance for CLABSI rate. And they were a big help in that. But one of the interesting things was they started to look at many other things related to our CLABSI rates, and that led to some significant insights. So we all suspect and know that the more times that you access a central line, the higher the risk of that line getting infected is. But no one's actually ever proven that mathematically. And so with this large amount of data that was used to create those bundle compliance dashboards, we could look at a significant number of lines and line days, and look at the average number of line accesses for patients who had CLABSIs versus those patients who didn't develop CLABSIs. And there was a statistically significant difference with the number of line accesses in patients who developed CLABSIs as compared to those who didn't. So that was one of the insights. The other thing where the students asked a lot of questions about was in the definition of CLABSI rate. So for any of these hospital-acquired conditions where there's a rate, the numerator is the number of events that you've had, and the denominator is the number of line days. And this gets to how is that denominator defined? And there is a national standard, the National Healthcare Safety Network, or NHSN, has definitions on how you calculate the number of line or catheter days. And basically what they say is a once-a-day count at a fixed time for all patients with a particular line or catheter. There are some surrogates that you can do most people do this. Note that the time needs to be fixed. You can't game the system by, on one day checking at 5 p.m., on another day checking at 10 a.m. To try to capture the most lines that you can each day. It has to be at the same time every day that you check how many patients have lines. But it doesn't say what time of day that you need to check. That is up to you. So what time do you think that we check for lines? And the answer to that is midnight. So why do we do it at midnight? And I think this purely relates to historic things. If you think back a long time ago in the pre-electronic health record, where the only way to count the number of patients was literally to walk around the hospital and count them, they did that at midnight because no patients were in radiology, no patients were getting rehab therapy, patients weren't out getting fresh air for their tuberculosis. They were all in their beds, in the wards, and they would manually walk around and count them. Unfortunately, that same time has translated into the electronic health record age, and we do most of our counting things at midnight. And there have been numerous articles, this one is my favorite as far as titles, about why the midnight census isn't an accurate way to depict census, because you can have wild swings of the census during the daytime, and also not a good way to check for line days. This one is titled Why I Got Fired, or the Dilemma of the Midnight Census. So with our students, we looked at what would be the difference in our rates if we did the line count in the morning as compared to at midnight, because as you can imagine, between patients being discharged or having their lines removed during the day, you're going to miss some of those patients if you count at midnight as compared to if you count sometime in the morning. And what they basically showed was that there was a 4 to 6% decrease in our CLABSI rate if we collected our line day information at 10 a.m. as compared to midnight. And I think this brings up two issues. One is we need to make sure that these processes are standardized nationally, that the time should be defined, because if different hospitals are using different times, we aren't comparing apples to apples. And secondly, we probably should use some time in the morning, because that more accurately captures the number of lines than does the midnight time. Now, central lines stay in place for a long time, so you might imagine the change between which time of day you count them may not be that dramatic. But something like urinary related catheters, which don't stay in that long, you could imagine that the effect of when you count the lines might even be more dramatic, and it is. This is a different publication that looked at that, and you can see when we counted the number of urinary catheter lines at 11 a.m. as compared to midnight, the urinary catheter days increased by 50%, and the CAUDI rate actually decreased by 33% if we counted at 11 a.m. as compared to midnight. So again, showing the importance of standardizing this nationally and advocating to change it to a morning collection time. So those are some of the things that we've learned through our work on CLABSIs. I'll switch now to pressure injuries or hospital-acquired pressure injuries, or HAPIs. So this is, again, our modified run rate for SPS reportable, or the higher level pressure injuries, and a very similar pattern as compared to the other graphs that we looked at. We started our work on pressure injuries a little bit later. This is the institutional wide work than we did on CLABSIs, and you can see that there we were 3 times the national benchmark in 2018, and through the work of the wound care nurses and many of the frontline nurses and nursing leaders, there was a dramatic reduction between 18 and 19 in the HAPI rate, and we went well below the national mean, which is the yellow line here. We had gradual slippage back up, but again, well below the baseline where we started. And this is kind of the typical pattern of a successful improvement initiative. As you begin to look at other things, things drift back up. But you can see in 2022, that rate is now back down below the national average. So again, great work here. I do want to point out with this red arrow that both in the months of September and November of this year, we were right on the rate of the national average. In both of those months, we had one SPS reportable pressure injury. So it takes very few pressure injuries to put your rate out of whack. So it just shows how difficult this task can be. This is a paper looking at some of the key things that were helpful in reducing the hospital-acquired pressure injuries. And not surprisingly, it is essentially the same three things: accountability, standardization, and data transparency, where all the key drivers were that drove this reduction. Now, as you can imagine, different patients have a different level of risk for developing pressure injuries. You know, patients who are ambulatory obviously have much less risk, and those that are in the ICU would have a much higher risk. So a predictive tool has been developed to look at pediatric patients to see who are the most at risk. And this is called the Braden QD score. It's a predictor for pressure injury risk. And basically the way it works is you get points for things, and our nurses record all this, and it goes into the electronic health record, and the Braden QD scale is calculated. So for mobility, sensory perception, friction and shear, nutrition, and tissue perfusion, you can get 0 for mobility, it's no limitation, 1 point for limited mobility, and 2 points for completely being immobile. And then for medical devices, you get 1 point per device, up to 8 points, plus another 2 for skin protection, which gives a potential total of 20 points. And the more points, the higher risk you have. Now, the Braden QD score has been advocated to be used as a cutoff. You can see that patients that have higher than 13 points are considered at risk, and those with less are considered not at risk. So this led us to look at certain things. One is, does the Braden QD score work? And our data shows that it does. Second, does it work like a cutoff, or is it a gradual increase in risk? And 3, does the performance of the Braden QD score actually change as you reduce your rate or you improve? So those are the questions that we set out to look at. This is the data around should it be viewed as continuous or a cutoff, and you can see that this is the HAPI incidence versus the Braden QD score, and you can see that this is 0 to 4, 5 to 8, 9 to 12, 13 to 16, and 17 to 20, and there is a gradual risk. This is looking at it logarithmically. So it shouldn't be thought of as a cutoff. You actually have a 41% increase in your risk of developing a pressure injury as you move from one set of scores to the next. This looks at the second question that I mentioned. Does the Braden QD performance change as you make improvements and your HAPI incidence decreases? And the answer is it changes. So, if you look at our HAPI incidence over the time, it decreased as we improve things. But the precision and the specificity of the Braden QD score deteriorated as the frequency of pressure injuries became less. And this is important because if you think about, if we develop a predictive model for anything that we're working on trying to improve, the time that you usually develop it and put the resources in developing it is when you have a big problem. and that you need to start an improvement initiative. So the model's built at the time that there's a high incidence of these things. And if that incidence then goes down, you have to recalculate your model because it'll begin to perform worse. So this just summarizes, it is a continuous risk. Every 1 point increase in the Braden QD score is associated with a 41% increase in the patient's odds of developing a pressure injury. And the effectiveness of the Braden QD score does decline as your incident rate gets less. So let's move on now. We've talked about serious safety events, CLABSI, and HAPIs. We'll now move on to venous thromboembolism. You know, unlike CLABSI and HAPIs, and serious safety events for that matter, where there's been a lot of national work and a lot is known about what to do to make the incidence less. That is not the case with pediatric venous thromboembolism. We know very little about it and very little about what to do to make the situation better. This has been dramatically increasing in frequency over the past decade. There really has been very little work about predictive tools. Some work has been done in trauma patients, but outside of that, there aren't really good predictive tools as to who's going to develop venous thromboembolism. And interestingly, the Solutions for Patient Safety has developed guidelines and bundles, but they state that those are exclusively for patients greater than 12 years of age and those patients who do not have central venous catheters. So one of the things we wanted to look at was if we looked at the number of patients that had venous thromboembolism in our population, how many met those Solutions for Patient Safety guidelines? And the bottom line is almost none of them do. That all of our patients that get thrombus in our institution are either less than 12 and or have a central line. So the SPS is not focusing on the right patients. So that's point number one. The second thing that we wanted to look at was, is there a good predictor for who's going to develop a venous thromboembolism? And we started to think about the Braden QD score, which was designed to assess the risk of pressure injuries. And if you look at those areas that assesses, you begin to wonder, well, these are also risks for developing VTE. And so we tested that thought, and it actually is that the Braden QD score is a very good predictor of who's going to develop venous thromboembolus. And you can see these are the buckets of the Braden QD scores, and this is the incidence of VTE. So it actually works very well. And interestingly, not only does the total Braden QD score work well, but all the individual components actually have a statistically significant prediction rate for who will develop venous thromboembolism. And actually, if you look at the AUROC for the Braden QD score in predicting venous thromboembolism, it is actually higher performing for that than it is for predicting pressure injuries. So we already have this data. It exists in the electronic health record at our institution and at most children's hospitals. And it is a useful way to think about who's at risk of venous thromboembolism as well. So that's a little bit about venous thromboembolism. I'm going to move on to key performance indicators and health equity. So particularly as we decrease our rates of some of these things, you know, and look for ways to further continue to improve, one thought is, if we can identify groups that are more at risk, we can concentrate our efforts on those things and we can therefore continue to not only make things better for them, but to improve our rates even more. And some of the social factors that may influence health equity of these types of things, some of which we've already talked about. We've looked at race and ethnicity, language preference, patient gender, payer, commercial versus state, and then the median household income based on the zip code of the patient's address. And just some demographic information about the patients that we serve. This is a combination of inpatients and outpatients. It's a little bit different for inpatients and outpatients. And when you look at both together, it more reflects the outpatients because they're so much more numerous. So for Packard, we have slightly more female than male patients, approximately, and this is according to data captured at registration in EPIC. About 83% of our patients have English as their preferred language, 14% Spanish, 2% Chinese dialects, all added together, and then 2% other. We are 67% commercially insured and 32% Medi-Cal and 1% self-pay. The reason this looks different than the numbers that finance sometimes uses, which is more like 40% public, is because this is the number of patients that fall into each category, whereas they look at the number of dollars that are charged dollars that fall into each category. And then we are approximately, the patients we serve are 24% white or Caucasian, equally the same number Hispanic, 20% unknown, and that's about 20% on the outpatient side. We capture this near 100% of the time on the inpatient side. And then 16% Asian, and different than many other children's hospitals, only 1% African American. So our makeup is different than many other children's hospitals. Then median household income by zip code. You know, zip code has been shown to be the best indicator for poverty in the United States, and it's been stated that your zip code may be more important than your genetic code in determining your health outcome, and that relates to epigenetics and the double hit of the risk when you are preconception to your first 1,000 days than the things that you're exposed to later in life. So zip code has been shown to be important. This shows our demographics for median household income bucketed into for the different buckets that the US Census uses. And these colored counties are the counties that we receive patients from. The darker blue is the more wealthy brackets, and the lighter blue is the less wealthy brackets. And you can see the wealth is obviously concentrated in the Bay Area and in Southern California, and less so elsewhere throughout California. And most of our patients fall in the middle, although we do have ones in the lower and higher income brackets as well, obviously. So one of the things we looked at was factors influencing health equity of influenza vaccination in pediatric patients. And you can see that almost everything we looked at, indicated by the red asterisks, was statistically significant. So if you're a child in our health system and you are non-English speaking, you have a less likely chance of getting vaccinated for influenza than if you speak English. If you have public insurance, you are less likely to be vaccinated than if you have commercial. And if you are Hispanic, you are less likely to be vaccinated than if you are of other ethnicities and races. And if you are Asian, you're more likely to be vaccinated than other races and ethnicities. And very interestingly, it is directly proportional to your median household income, how likely or not you are to get vaccinated. So those patients from the poorest zip codes are much less likely than those from the wealthy zip codes to be vaccinated. So there are many reasons why this might be. Some that are more and some that are less in our control. A lack of a strong recommendation for the provider. Provider recommendation is one of the strongest things that correlates with influenza vaccination. You know, linguistically competent care, patient and family health literacy, access, low income and poverty, and accurate data on social groups all could contribute to this. And so therefore, having an action plan to try to improve our influenza vaccination rate has to take those things into consideration and have a plan for those. The other thing that's interesting is looking solely at median household income and our performance on key performance indicators that relate to pediatric inpatient care. There have been a ton of things published on ambulatory factors that are influenced by social things that create health disparities. But what about things that are more completely in our control inside of the hospital? And interestingly, if we look at pressure injuries, although all the other things that we looked at did not have statistically significant differences, the median household income did. And those patients in the lowest bracket have a higher rate of pressure injuries than the other brackets, and those were statistically significant. We see similar trends, although not statistically significant, probably because of the very low numbers, both for CLABSIs, again, higher rates in the poorer patients, as well as for codes outside the ICU, higher rates for poor patients. And again, as we work on our plans to improve our performance in those things, I think we need to take into those social factors into account and have those as part of our action plans. So the last two things I'll try to address briefly are US News and World Report and then managing complexity. So we have a US News and World Report gap closure process. This tries to keep this front and center throughout the year. We fill out the survey and turn it in February. We look at what we've turned in and try to calculate where our gaps are. And then we ask each of the 10 pediatric subspecialty teams, as well as any teams formed for institutional-wide issues, to develop a 200-day plan to try to close those gaps. And then those teams all report out in front of hospital and physician leadership at sometime in the end of May in what we call the 200-day plan report out. We then get our results for the prior year. We reassess what our gaps are, and we then give those gaps to the teams, and they have 100 days until before we actually fill out the cycle. And then we have another report out in December-ish to discuss where we are on those gaps. I think that approach has served us well in the sense that we went from having 85 points to 140 points and moved from a ranking of 20th to 10th in 2 years, 2 cycles, and then maintained that cycle last year, which was a little bit of a weird year because of COVID. But there were 3 things that really equally contributed to our improvements. Getting magnet status was huge. And then improvement in our system-wide quality indicators, many of the things we've talked about here today, mainly CLABSI and pressure injury rates. And then the individual 10 pediatric subspecialty teams closing gaps within those areas were the other third. So without any one of those, we wouldn't be in the top 10 right now. And those 3 areas will all be critical as we move forward. I'm going to skip that on the basis of time and finish with just talking a little bit about the importance of having a socio-technical approach in managing complexity. So we have this lean conference every year. Edgar Schein, who's a behavior-related person and one of the fathers of the science of discussing the culture of things at work, in the workplace. And John Shook, who's more of a process-oriented guy, a lean person, they always have these debates at our annual lean conference over which is more important, process or the social factors. And basically, after one of those debates, we got them to agree to try to come to agreement in writing an article on what's important. And the bottom line is that for optimal execution, you have to have deliberate consideration of both the technical domain, your tasks, processes, and how the work is being done, as well as the social domain of how those doing that work interact. And if you neglect either of those, your chance of success are less. Some of the things in the technical domain can very much shape culture. Some of those things that we do in our organization, the daily management systems, having a problem-solving accountability mechanism, goal setting and deployment, having a built-in process for recognition to try to change that culturally, and many other things are on the technical side. And the technical people would argue that those processes you should focus on to then shape your culture. And we have numerous examples of these. Again, for time, I'm going to skip some of this stuff. On the other side, on the social side, making sure that we work on teamwork and communication things, how things are escalated is very important as well. So deliberate consideration of both of those. And I think thinking of it this way is very important when we start talking about patient complexity. And this is our case mix index over time. This is a measure of how complex the patients we serve are. And you can see that, back here, I can tell you that we as a children's hospital had the highest CMI of any children's hospital in the United States. And we've only become more complex as the pandemic has hit us. So what are the important things in managing that complexity? Healthcare has been likened, and we've heard this here at various grand rounds, to needing to be modeled after the airline industry, that we need to strive to have zero errors, that we need to have checklists and things like that, and all those things are super important. The challenge is that, at the bedside of these complex patients, it doesn't look anything like a checklist, like a cockpit. There is standard work for each of the different pieces of equipment in the room and checklists related to those, but for the patients managing these kids with the changing condition of the children from hour to hour, what does their day look like? It's very different than a cockpit or checklists. And is it even conceivable that working in such an environment that we would ever be at a time where there would be zero errors, or should we anticipate that errors are going to occur and make sure that we have processes to try to mitigate those errors and identify those errors as quickly as possible? So in managing complexity, I do believe you have to have a socio-technical approach. All of those technical things that we've talked about are super important, but you also need to balance that with a culture of trust and listening, a culture where people speak up, that we anticipate that errors are going to occur and mitigate those as fast as possible, and that when appropriate, people aren't blindly following protocol, but make timely adjustments based on what is actually going on with the patient. So those are the things that I wanted to review today. Again, thank you very much for your attention. And also, it has been a great pleasure to serve as your Chief Quality Officer over the 4+ last years. And I wish the organization all the best. Thank you. Be happy to answer any questions.
Thank you, Lane. And there are lots of great questions. I just want to think, when I harken back to having the privilege of serving on the search committee for the Chief Quality Officer, one of the most important things to me was that we find opportunities to do interdisciplinary work and really meaningful scholarly work with the faculty in the Department of Peds. And it was so impressive to see all those publications. So thank you for that. I also really appreciate that you did a critical appraisal of a lot of the methods and how interdisciplinary this was, and of course the health equity piece. So with that, I'm going to start with the health equity questions. We have a thought about using the HPI, Healthy Places Index, as opposed to zip codes.
We have not done that analysis. Well, when I say we, that analysis was done by our data analytics group within quality and safety. And we have not done analyses beyond what we've done. Obviously, I think we should be open to doing other analyses. And obviously, there's also so many different teams of people working on health equity things. I think making sure that we share those best practices between all of those groups to optimize our efforts is important. So we haven't, but we'd certainly be open to.
Yeah, no, thank you. And many people know that Lisa Chamberlain just launched the Office of Child Health Equity. So she and I have been texting about how to strengthen those connections. So turning to Lisa's question, Lane, thanks for your leadership in this space and for weaving in the social influencers of health into your thinking. What do you think is the next most important step for us to take regarding equity? And the options are better data, other things, and where are we on health equity dashboards?
So, yeah, obviously, well, I think it's a combination of those things. Health equity dashboards. I'll just talk about some of the things that we've been struggling with. If you look at, the initial, I don't know if dashboard is even the right word. The initial analysis we did of that work took a 2-year period of time. And, we think of hospital-acquired conditions and serious safety events as being common because we work with them all the time, but they're actually, in a mathematical sense, pretty rare events. And it took 2 years of data to even have enough single institution information to do an analysis of. So our take has been that this, unlike our key performance indicator dashboard or slide deck that comes out every month, or you can go online obviously and look at this on any day that you want to. That brief time period of analyzing for changes related to social factors probably doesn't allow enough data to be interpretable, and that our thought was that this probably would lend itself, at least on the inpatient side, to an annual evaluation of where we were, or you just wouldn't have the numbers to be able to compare. So Ling Lo and our ACE or data analytics team is in the process of looking at, and they've created the first draft of this already, the 2021 data, and comparing that to our baseline data, which was 19 and 20, and to see, which direction things are changing in. I'm struggling with how you could do that any more frequently than that. So that's kind of where we are on thinking about things for that particular analysis.
Yeah, thank you. And I think it's also interesting to think about how we pull in some of the expertise across the campus. So David, well, first of all, I love seeing what David Schenker has done and bringing in mathematics, but also David Rakoff in the Department of Epi and Population Health Sciences, I think is very sophisticated on how we use census tract data. And Lisa's also working with people in the School of Education around devices and Wi-Fi access and disparities therein. Okay, some of the vaccination data generated some really good questions. Has anyone discussed the issue of vaccination mandates for hospital care in ways that have been legislated for schools and required for employment, as in Stanford healthcare divisions?
Yeah, I'm not, well, just to clarify, I think this is not part of the question, but that data obviously looked at patients, right? That was influenza vaccination of in primarily the ambulatory setting of patients. So that's very different than some of the challenges that we have on the employment side, as far as making sure that everybody's had their vaccinations each year, as we all know from recent experiences. So I'm sorry, can you
This is about vaccination mandates for hospital care. I think the question is just getting in that you have to, I'm assuming for patients, that as something that I don't know if it's actually, you have to be vaccinated to get your care here. I mean, I know there's been a lot of discussion on the vaccine prioritization and principles committee that Grace Lee and Bonnie and others do around what options do we have about having to have vaccines be able to come in to help protect the workforce. And there's real concerns that would then impact health equity and create some biases. So I'm not exactly sure what the question person's getting at, but maybe they can clarify if you want to say anything further. And then there's another vaccine question. Do we immunize at discharge?
I don't think, I don't think we have a systematic way to do that, to my knowledge.
Okay. And then the prior question clarified, do we require patients to get vaccinated for care at Packard? I think that's very much what this Principles and Priorities Committee is looking at. I don't know if you have anything to add, Lane, but we can.
I don't believe that's currly true, right?
No, it's
we don't
definitely
vaccinate.
not true. And there's been discussions about requiring it in order to protect the healthcare workforce, and the answer has been no. We're not going to require that to get care. So I think, Dr. Leibowitz, the short answer to your question is no, but it's an active area of discussion. Okay, let's go to another. Here's a good one. I think I know the answer, but have we seen a change in annual influenza vaccination rates in the past 2 years? And is there an effect linked to COVID-19 vaccination rates?
Those are great questions. I would say that um, there are two parts that we look at as far as vaccination rates. So one is driven by US News and World Report, fortunately or not, and that is in these very at-risk populations. There's 10 of those populations, and those are kids with asthma and various other groups of kids. And we've had a longer history of looking at those groups and trying to put processes in place to make sure that those at-risk kids get vaccinated. So we have a longer history of looking at that. And, up until the pandemic, we were making progress in increasing the rate that each of those 10 groups of kids were getting vaccinated in. And I think the best that we had gotten to was the goal in most of those groups is to hit 90%. And we had hit all of those groups. We had hit 8 of the 10 of those groups, that 90% mark. That deteriorated during COVID because, many of those patients in those at-risk groups live far from here and didn't want to come in just to get their influenza vaccination and be put at risk of getting exposed in the clinic and things along those lines. So we actually had a worse rate for influenza vaccination in those groups over the last year. We have a much less historic experience in looking at our overall vaccination rate in the ambulatory setting for all kids that we see as a group. And we really have focused on that, I would say, much more in the past 2 to 3 years, and that rate was improving. And again, in COVID, it was a much more difficult issue for multiple reasons. And obviously also the focus on that changed a little bit with when COVID vaccinations came up and things along those lines.
All right, we're short on time, but there's 2 really good questions, so we'll try to move quickly. And was there action taken to present a request to NHSE to standardize time of counts for infections to lead the charge to improve monitoring for our nation? And I have to say, the fact that that paper was in JAMA is pretty amazing. But where does it go now?
So, we are trying to push that issue, both by, there have been some communications to them, but also to publish those articles so it's out in the public domain, the differences, to try to emphasize that as well. And then I would say the other big player and we've just become more aware of this, but evidently right now Epic cannot measure at any time except at midnight. And so they're another player in, trying to allow us to standardize and change those times. You have to be able to do it within your electronic health record. And my understanding is right now you cannot.
Good. And then the last question, I think, is just a question of how we standardize some of these things. And I think since these are rates, it probably is standardized, but is the long stretch of SS3 in 2021 related to less children being admitted during the pandemic?
No, we don't think so. And like you said, because it's based on the number of patient days, it is standardized for that changes in volume.
I actually thought it would go up because the only kids were getting admitted were the sickest of the sick kids, not the more elective. And then I'm going to close with a comment from Roshni. She wants to express your deep gratitude to you for your exemplary leadership. It's been an honor and pleasure to work with you. Such remarkable achievements in so many aspects of patient safety over the last 4 years. So on behalf of all of us, thank you, Lane.
Thank you, Roshni. Thank you, everybody. It's been nothing but a pleasure.
Thanks, everybody. We'll leave this open for just a minute.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.